finally, we have our last speaker, Dr. Nidhi. We'll be talking about how AMT is used as an adjunct for various surface surgeries. And after that, we can have all the questions and doubts and discussions.
Good morning, everyone. Thank you, Dr. Soham, for making me a part of this IC. So I'll be covering how amniotic membrane can be used as an adjunct to ocular surface surgeries. And here we have multiple indications. Let's just see the most commonly scenarios that we face. Coming to persistent epithelial defects, now the cases which are intolerant or refractory to conventional treatment, like lubricants, punctal occlusion, a bandage contact lens, or tarsography, we can use an amniotic membrane here. So this is a case of a post-infective keratitis with a PED. So it is important to first roughen up the edges because a long-standing PED, the epithelium will not grow. Sometimes you also have to excise the redundant epithelium and put the amniotic membrane with a glue or maybe with sutures. So you can put individual sutures or you can put a 360-degree purse string suture. This is another case who underwent ALK for dermoid, and it was a pediatric case having a PED. So here I did not use a suture, I just put it with glue because then again the patient would have had to go under anesthesia and the patient healed well. Another indication is using in ocular surface surgeries alternatively to conjunctival grafts where there is a very large conjunctival defect in primary double-headed pterygioms, or it can be combined with the conjunctival autograft in recurrent pterygioms. So this is a case who had 3 surgeries for nasal and temporal pterygium, and this was the 4th recurrence. And this patient, I used CLAG for both the sides, only half of it, and the rest of it was covered with amniotic membrane, and the patient is doing good for 1 year now. Now this is a case just like Aditya sir showed, scleral melt post pterygium excision, but here the melt was quite large and you could see the uvea as well. So here, even on giving the block, there was some bleeding in the anterior chamber. Conjunctiva was quite adherent, so first it was released and I isolated the medial rectus to avoid any injury. Then a hand fashion graft was placed. Again, there was not much conjunctiva here or tenons, so I put an amniotic layer first and then I took a CLAG from the other eye. Unfortunately, this patient was lost to follow-up, so I really don't know how he's doing, but from my side, this is the best that I could do in this case. This is another case of a scleral graft melt in rheumatoid arthritis. Already one sitting of amniotic membrane and scleral grafting was done, and then the patient presented with this like a stuck-on appearance of the graft. There was an impending choroidal detachment, vitritis was present. Doing any kind of grafting in such autoimmune cases is very risky because that can also melt. So first the patient was sent to a rheumatologist where she was given pulse dose steroids intravenously, and then intravenous methotrexate was given. That was the choice from the rheumatologist. And once the patient stabilized a little bit, the vitritis reduced, I did try to do a regraft here. So the previous graft was actually stuck on, so that had to be removed, and then this graft was placed. There was quite a large defect and the surrounding sclera was also quite thin, so I could not really rotate the sutures, and I thought that a single layer amniotic membrane would not be enough. So a second layer was put and a tarsography was done after that. All the systemic treatment was continued, and this is how it looked at 2 weeks, 2 months, and we are waiting for the vascularization to happen, but no melt. 4 months. And this is at 6 months, and planning to do the suture removal now. Another indication that sir has covered is using amniotic membrane in VKC for ulcers or giant papillae. Coming to perforations, that is most commonly seen by all of us. Here a multi-layered amniotic membrane can be used, or it can be used along with tissue or Tenon's graft. So this is a case of patient having a very long-standing foreign body which induced stromal necrosis. So what we need to remember is whenever we are removing the foreign body, all of it should be removed, else the residual iron foreign body or any other foreign body will either cause an infective keratitis or will cause stromal necrosis. So on removing, I saw residual foreign body still there, and there was a perforation which could not be handled with cyanoacrylate glue. So a lamellar pocket was made here so that I could do a multi-layered amniotic membrane. So first layer was inserted into the pocket with glue and then covered with a second layer with glue and sutures. However, on forming the AC, I was not sure that it would sustain or not on follow-up. So just a thin layer of cyanoacrylate glue was put, which I thought I'll remove very early. And this is how the patient looked at 1 week. And this is after the glue and suture removal of the patient. This is another case who was a case of failed glue BCL done by me only. And the patient came with a flat AC after 3 weeks. And earlier there was a central thinning, but now the adjacent tissue also had thinned out quite a bit. Now this patient was on warfarin, and we could not plan a keratoplasty for her. She was not given clearance for a surgery. So on that day, whatever was available, my plan was to put it there, either Tenon's or multi-layer amniotic. But I had a very small cap of desect tissue, which was fresh, and that is what I planned to put here. So first layer was inserted into the lamella, and the second layer of desect cap was sutured. This is how the patient looked at 3 weeks. We had a good thickness achieved in the center, and this is at 12 weeks. Now the patient is awaiting clearance for a keratoplasty. Now this is a case of stromal melt. There is not a frank perforation. This patient had B-cell lymphoma and had undergone radiotherapy and then developed a 7th nerve palsy and lag of thalamus, and that's how he had exposure keratitis and a stromal melt. And here again, an amniotic membrane with the residual desect cap was used. Sometimes if we do not have any tissue, obviously Tenon's comes to the rescue. Tenon's is quite elastic, so even a small graft would suffice. So here sutures have to be given because it swells up later on and then it can get dislocated. Another case, this is a one-eyed case, post-traumatic, previously recorded 0.9 CDR. There was a bleb leak, and for that I put a large size BCL first, but on follow-up there still was a leak. So then here I plan to form the AC and do a graft. So amniotic membrane can be used to repair blebs. Due to long-standing flat AC, a lot of anterior synechiae had formed. Normally, if we have a leaking bleb, we might just remove the conjunctiva and put an amniotic graft as an inlay. But here, the rest of the tissue was quite tough, so I just thought of lifting it up and placing amniotic membrane as an inlay inside. this patient did quite well. His IOP was very well maintained, bleb was formed, and later on a cataract surgery was done, and he has ambulatory vision in one eye. This is a case post-SICS who had a tunnel deroofing, and it was just impending perforation. You could see the anterior chamber from the superior aspect. And so here, as I started the surgery, there was a perforation. There's no history of trauma. His IOL has been placed like that only since the beginning. And here, again, a hand-cut graft was used, covered by amniotic membrane. However, the rest of the conjunctiva I felt inadequate to cover the graft, so I just took a small inferior autograft. And the patient is maintaining 6/9 vision since then, awaiting suture removal. Another indication is to remove OSSN or any suspected mass. Here, what you need to take care is you need to have an adequate free margin on all the sides, including the epithelial site, which needs to be sent for histopathology. And the tumor is removed with a no-touch technique. A double cryothaw is done, and then you put glue and the amniotic membrane and cover it with BCL. This was the post-op of the patient. So thus, there are various presentations of OSSN for which amniotic membrane can be used. This was a very challenging case which had 8 clock hours of OSSN. And removing this and putting an amniotic membrane, there is a very high risk of causing a LSCD, but this patient did well. Another indication is to remove symblepharon. Now this patient presented 6 months after chemical injury with a symblepharon, and what I did was I used a conjunctival autograft near the limbus, and for the rest of the symblepharon excision and covering up, I used the amniotic membrane. And this is a case which actually had undergone amniotic membrane transplantation after a chemical injury, and then 6 months later had a symblepharon. So it is not that patients who have not got treatment will have a symblepharon and who have got would not. This can happen to patients who are doing well also. If they are lost to follow-up many times, or if you stop using the steroids, then chronically they might develop a symblepharon and pannus. So this is how the post-op looks for this patient. This is another indication. Patients having very long-standing status post-chemical injury will require a combined procedure of symblepharon excision as well as doing a slit. And amniotic membrane is very important here. First, you need to find a plane and excise all the pannus. And then you take the limbal cells from the other eye, cover the bed with amniotic membrane with glue, and then place the small lenticules over the cornea and then attach them with the fibrin glue. And then cover up with the bandage contact lens. So this is how this patient looks at 3 weeks, but still awaiting follow-up of this patient. So to summarize, amniotic membrane is a very good adjunct for ocular surface surgeries, and anything that you need to plug, prevent or protect, amniotic membrane can be used. Thank you so much for your patient hearing.
It was a wonderful collection of surgeries, Nidhi. Thank you so much. So we are now open for any questions and any comments you are free to ask. We still have about 15 minutes to go. post-surgery medical management. Would you like to answer, sir?
So, for chemical injuries, what I feel that you should give these steroids, topical steroids. In cases, if there is grade 6 injury, there is scleral ischemia where you did this tenonplasty, then you have to go for oral steroids also. So topical steroids initially for 10 days you have to give the strong like dexamethasone or prednisolone acetate 2 hourly along with this antibiotic coverage and mediatrics, then this like this collagenase inhibitors like doxycycline, and then these patients have usually some sort of glaucoma, so you have to give this oral acetazolamide, and then lubricating eye drops. And if the patient still now is not getting better, or after sometimes you feel that this ocular defect is persisting, then we can go for this umbilical cord serum, or even this topical amniotic membrane extract also nowadays, but we have not used so far like that. ভাই এটা একটু বন্ধ করে দাও না, দেখো কি হচ্ছে এখানে। Immunomodulators at this stage won't help because it is acute conditions. So in this case only oral steroids may help, but thing is that the mainstay of treatment is tenonplasty or scleral patch graft.
It induces more inflammation and fibrosis. So the better option is to just shave it off and then put a AMT. There have been published reports in the literature that there is recurrence in spite of applying AMT. So MMG has also been advocated by one group that instead of putting a amniotic membrane, just put a buccal mucous membrane graft.
Cryotherapy will definitely cause that means this fibrosis, and sometimes they can develop the cicatricial entropion also. Okay, so if you just cut it, and sometimes if you have diamonger polisher, you can just polish it. And I have found that if you put this topical bumonidine or anything like that, this bleeding will stop. And then if there is some oozing of blood, if you put this amniotic membrane, that oozed blood will act as a